Welcome everyone to another session of LEJEndo, Lister Endometriosis Journal Club, which takes place on the 6th of every month, even in the middle of the summer, at 6 p.m. UK time. More and more of our audience tend to now watch things online, but if you want to be part of the discussion, please spread the words and get your colleagues to come and join us. This webinar is a joint venture with Karl Storz UK, and we're very grateful for their support. It is also something that we've been doing with the support of EEL. The idea is to present some short version of recently published papers on endometriosis, and then we invite one person to present a publication that they've been involved in as a featured presenter. And today we have Munazzah Rafiq, who's a senior trainee in Oxford, and is going to talk to us about their study, which we will get to. The team you will be familiar with, Flo Britton, who's behind organizing the webinars this year, is my current fellow. Avril Bachi has been very active in the organization and in presenting in the webinars. Avril worked with me a couple of years ago. Sarah Rizek is also another one of our trainees who has been a frequent flyer on the LEJEndo and very kindly and very nicely has been contributing to these. And Munazzah I already introduced. So let's start with the first paper.
Hi, good evening, everyone. So I'll be presenting a paper that looks at AI uses in endometriosis. This was a scoping review published in Nature in 2022. And it was just, I wanted to see how we're using AI basically overall in endometriosis. And this was a good sort of summary paper. Next slide. So this study basically aimed to examine and try to sort of actually summarize how AI is being applied currently in endometriosis. Next slide. To be able to generate some sort of comparison between these AI models, the authors had to try and make a sort of schematic overview of how AI can or is being used in general in endometriosis and in general in surgery. So at the top there, it shows you have the AI, you have to feed it data, whether that be raw data, labeled data, or unlabeled data, and that's how you have your initial input, you can see there. Then it's the type of data you're putting in. So are you putting in ultrasound findings? Is it clinical history? Is it blood test results? So serum biomarkers, peritoneal fluid markers, which we know are being researched in endometriosis. Then from there, the AI needs to have some sort of evaluation metric, sensitivity, specificity. So it needs to be used to actually have a predictive value or detecting the presence or not presence of endometriosis, for example. And then within the AI model, there needs to be some sort of cross-validation method, whether that be internal or external. Then from there, you get your results from the AI model, and they suggest you could apply it to improve your diagnosis, to generate personalized treatment options, perhaps to predict post-operative outcomes, to understand the disease progression in endometriosis long-term, and maybe even to improve our staging and sort of how we type the endometriosis. Next slide. So they did a database search looking at all the major databases we see at the top there, and they identified 1,309 studies, but only 36 studies were included. Essentially, the studies that were eligible needed to be ones that were in English, conducted on humans, and they needed to have basically an AI model that was used to explore endometriosis, whether that be in diagnosis, prediction, or management, basically. And the AI had to have some sort of reported evaluation metric, a sensitivity or a specificity. And the exclusion was, of course, the opposite of that. Next slide. So this is a summary of all the studies they found and how they tried to generate some sort of comparison. Like I said, this is a scoping review. It was just almost a descriptive comparison, really. And we'll go straight into the results on the next slide. So first of all, they looked at what kind of studies were being used with AI, and the vast majority were retrospective studies. There were no high value RCTs, and the average sample size was 245 individuals. The next way they again tried to generate some sort of comparison between the studies was looking at the purpose of the AI model. And the three ways that they found it could be used is either to improve research efficacy, to improve your diagnosis in endometriosis, or to generate some sort of predictive outcome model. Interestingly, we aren't very interested in using it for research efficacy. That was only 8% of studies, but the vast majority were used for either diagnosing or making some sort of prediction in the field of endometriosis. And a common one was for fertility outcomes. Next slide. They then summarized the AI intervention method used, and essentially that's a list there. And just the thing I can conclude was that logistic regression was the most commonly used in the studies, but essentially it was all of those that were used there. Next slide. They then went to, again, trying to compare studies. They wanted to know what the sensitivity and specificity was of each model, and they pooled those. And the summary they made is that there was a pooled sensitivity of 80 to 96%, so quite broad, and a pooled specificity of 70 to 91%. So again, they then made another category to try and make a comparison, and they looked at the data that was being input into the AI. If we go into the next slide. So these were the 6 categories they came up with. So were you putting in results of biomarkers, so mRNA, cytokines? Were they putting in protein spectra results? Were they putting in clinical variable results? Age was the most commonly used variable. Things like VAS scores for dysmenorrhea, dyspareunia were commonly used. Genetic variables, so microbiome data, methylomics. There was then a category of mixed variables. So here it's where they tried to use AI to put in ultrasound findings, examination findings, and history all into one. And then the last category was imaging. So putting in things like, was there the presence of a sliding sign at ultrasound? Was there disease detected in the pouch of Douglas? And they then summarized the sensitivity and specificity of all of these models. And overall, again, just a brief summary is that the sensitivity and specificity were high. And actually, yes, you can go forward there, Flo, and to the next slide again. So in summary, they essentially concluded that there was limited comparability between these studies. You can't do a meta-analysis in this field, but they have generated some sort of comparison. They've been able to conclude that we are using AI, and the vast majority of studies were from the last 5 years. So it's up and coming. AI is really novel. It's really promising, basically. They found that it's very commonly used for predictive models. So that probably feeds off from fertility, the field of fertility. So predicting, for example, if after endometriosis surgery, your pregnancy rate increases. And they've said essentially it's got a really good future potential to improve our ability to diagnose endometriosis in a non-invasive manner, but also be able to perhaps predict whether somebody's symptoms would improve after surgery, for example. They have just made the recommendation that in general with AI, we need to describe the method so that it can be reproducible, move towards prospective studies rather than retrospective studies, and report the sensitivity and specificity. And that's all from that study.
Perfect. Thank you, Sarah. It was interesting that they had to say that they excluded studies that were not on humans. So there were studies that was on endometriosis, non-human AI. That's
yeah, it isn't. Yeah,
that's very niche. That's very niche. So I can't tell you much without disclosing international secret, but Flo is leading a study on AI in endometriosis, and we have to kill you if we tell you details. But ours is going to be a lot more interesting, I think. But it's, watch the space. This is going to be a booming area of for research. It really has changed every aspect of our lives, and it will continue to do so. And I don't think it will be different in endometriosis. And I was interested in seeing the five different categories of implications and applications of AI that they've listed, and they did put classification and pelvic mapping basically in there as well. But thanks very much. Thanks for choosing this.
So I will be presenting on the next paper. So this study was done by a team from South Korea and recently published in the International Journal of Obstetrics and Gynecology last month. And the aim of this study was to evaluate whether or not the use of Dianogest exposure is associated with breast cancer, endometrial cancer, or tubo-ovarian cancer in women with endometriosis. Next slide, please. So this was a retrospective observational study. They used the Korean Health Insurance Review and Assessment Service database, and they identified women between the age of 20 to 49 with endometriosis based on the ICD-10 code, and the study period ranged from January 2012 to December 2023, so a period of 11 years. These women need to have been on Dianogest for at least 6 months, and they were compared with GnRH agonists, which is their control. And on this paper, it said why they use GnRH agonists as a control is because this have been the treatment of choice for post-operative hormonal suppression in women with endo, which was quite interesting because in the UK, it's usually as a pre-surgery treatment rather than a post-surgery treatment, but I guess that's what they practice in South Korea. And why they have opted for a cutoff of 6 months for Dianogest use is because studies have shown that in patients taking combined pill for more than 6 months, it has shown an increase in estrogen receptor positive breast cancer.
Sorry, say that last sentence again.
So why they've opted for Dianogest to be used for at least 6 months is because studies have shown in those who take combined pill for more than 6 months have an increased risk of estrogen receptor positive breast cancer.
Okay.
In terms of exclusion criteria, obviously those who already have the corresponding cancer without before the medication got started, those who had bilateral oophorectomy, they were excluded from the ovarian cancer analysis. Those who had a hysterectomy excluded from the endometrial cancer analysis. They classified those who had pre-existing cancer is if the diagnosis was made within 2 years of the prescription because of the possibility of undiagnosed cancer at the time of prescription. Okay, next slide. So essentially, this is the result. What it has shown was that they observed similar cancer incidence rate between the two groups, the GnRH agonist group and the Dianogest group. And this null association remained after prolonged Dianogest treatment, except for breast cancer. So if we move on to the next slide. So they did a stratified analysis, and if you looked here on the under breast cancer Dianogest, 1.5 to 2.5 years, 0.5 to 1.5 years, the adjusted hazard ratio for breast cancer was lower amongst individuals. The longer the duration of Dianogest use, the direction of association varied across the strata, and the confidence interval was imprecise. In the endometrial cancer and the ovarian cancer group, the direction of association was inconsistent across the duration categories, with no incident case observed amongst those with individuals of more than 2.5 years of Dianogest used. So yeah, that's it from this study. So the conclusion, using GnRH agonists as an active comparator, they observed similar cancer incidence across the two groups, and this null association remained after prolonged Dianogest treatment except for breast cancer. Their findings support the oncologic safety of Dianogest with respect to breast cancer. And although earlier observational work linked to progestin-based hormone therapies increases the breast cancer risk, the present null association suggests that Dianogest may differ pharmacodynamically from other progestins. And yeah, that's all from me.
So just let's think about this for a second. Maybe I'm not understanding it. So they are comparing Dynagest with GnRH agonists.
Correct.
Now, GnRH agonists are supposed to reduce the risk of cancer. Is that not right?
Yeah,
For
obviously, because
estrogen,
there's no
yeah.
estrogen, so estrogen receptor
So
breast
we
cancer.
are, so if we're comparing the two, I mean, even if Dynagest, I mean, it's not relevant to this study, but even if we had shown that Dynagest patients are more likely to get breast cancer compared to GnRH analogs, it doesn't tell you that Dynagest will put you at risk in a normal population. Yes? So they're comparing it with something that is supposed to reduce the risk of breast cancer. And they're saying that this is on par. It's not worse or better. It's the same. So maybe you can even argue that it has a similar effect in reducing breast cancer risk. Um, I think the length of treatment is probably not enough to be able to extrapolate, but it's an interesting comparison anyway.
Yeah, the only reason they used it as a comparison is because that
They
was,
do it
yeah.
routinely.
Mm.
Some surgeons still do that here in the UK. In somebody who has very bad disease, particularly endometriomas, if they're already on GnRH analogs before the operation for other reasons, because I normally don't use it. If they are on it, I will say to continue for at least 3 to 6 months after surgery until they heal completely and all the rest of it. Okay, well, thank you very much.
I guess what would be a more appropriate study is if they compared Dianagest and non-Dianagest use.
Yeah, that's what I mean. That then you can make some conclusion about the effect of Dynagest on normal people. Now, I wonder if there is a study somewhere that looks at the risk of Dynagest in general in patients who've been on it long term. I remember seeing a study on bone health and Dynagest, which I think presented here. Am I right?
Yeah, sounds very familiar. And
Remember, guys, I just putting you on the spot. Do you remember what it said?
no, not
I
me.
don't remember the specific study, but I know in general the emerging results are that Dynagest does impact bone health negatively. Just that's the emerging results at the moment.
And the
Okay.
long-term use you should be monitoring with DEXA.
Yeah. Yeah, we normally do that for our patients, although we don't have many patients on long-term Dynagest, maybe a very few. Okay, so I think it's time for Munazzah's presentation. So Munazzah is a senior trainee in Oxford. They've done a really interesting study on, again, GnRH analogs and endometriosis. And just to give you a little bit of background on this topic, maybe Munazzah will cover it. This is a very common practice in the UK, and it even is in the NICE guidelines that if somebody has endometriomas, put them on GnRH analogs and then operate. I personally don't do that. I rarely use GnRH analogs, and there are a few reasons for that. But I understand the rationale behind it. It would be now, instead of just relying on rationale, it would be good to see what the actual evidence is for it. So, Monaza, please.
Thank you. Can everyone see the slide, please?
Yes.
Okay, thank you. I'm Munaza, I'm ST6 in John Radcliffe Hospital, OUH, and it's my pleasure to present today one of the research work that I have done. There are no conflict of interest. I did get a BSc research grant for this project. This paper has recently been published in Facts, Views, and Vision, and I am really thankful for the wonderful team that was with me in completing this project. This is a short abstract of the research that we have done, and the important thing was what is new in this, and we find that preoperative GnRH use is associated with increased risk of having perioperative and late complication. Therefore, it is just balancing the risk of complication and offering the GnRH preoperatively to the patient who are going to have the surgery for rectovaginal or colorectal endometriosis. A bit of quick introduction on deep endometriosis. We will be including all the patients that have either rectovaginal or colorectal endometriosis. This is the inclusion criteria. We all know that most of the patients do present with a lot of chronic pelvic pain, dyschezia, dysmenorrhea, and there are medical and the surgical treatment are available. And the main rationale of all these treatments is to reduce the pain and improve the quality of life. The surgical option for rectovaginal endometriosis is challenging, and this is why, because it is associated with complications as well. Whether we should use medical therapies like GnRH agonist as preoperative adjuvant, it is still not the question that has been answered. We do find very limited data that the association of preoperative GnRH can cause a reduced inflammation and vascularization. In terms of the ASHRI guideline that has recently been published, it says very less certainty about the preoperative use of GnRH. BSG database is the largest pool of prospectively collected data from the patients that have deep rectovaginal or colorectal surgery. And it also includes the information whether these patients receive preoperative GnRH or not. The main objective of the paper was to find out the association between the preoperative GnRH use and whether these patients have any complications, and to see that how is the quality of life. So basically, we were looking at the surgical outcome for those patients who have surgery for deep endometriosis and had received preoperative GnRH. How we did that, we took SAG approval for that, which is the Scientific Advisory Group of BSG, and all the data is collected prospectively on this national, in fact, it is international BSG database. All the patients who have surgery for deep rectovaginal or colorectal endometriosis from 2009 to 2021 were included. All the patients have pararectal dissection, and the procedure was done either shaving, disc resection, segmental bowel resection. For the purpose of the study, we have divided the patients into two groups. The one pre-GnRH-A, which received GnRH preoperatively, and the one who didn't receive were labeled as N pre-GnRH in this study. For the quality of life, all the patients who have filled up preoperative and at least one postoperative questionnaire were included. We used our version, and we have done different statistical tests just to make sure that we have produced the results that are statistically very sound. Our cohort was based on 9,433 surgical cases in which the preoperative GnRH was used around in 35% of the cases, whereas no preoperative GnRH was used in 65% of the cases. There was no response entry for perioperative complications in 12% of the cases. So most of the time they include either yes or no, but in 12% of the cases there was no entry. And in about 33% of the cases, there was no entry about the late complication. The type of the bowel surgery most commonly was performed shaving in almost 90% of the cases, and the second one was the segmental resection, followed by disc resection. If we look at the demographics and the operative difference between both the groups, both of the groups, since we have a huge group, we took the mean. It was a normally distributed the population, and most of the characteristics, including age BMI, smoking, and hysterectomy were similar. There was also similarity in terms of what type of the bowel surgery they have and surgical complexity as well. In terms of when I say surgical complexity, it means like high complexity cases were those which have a ureteric bladder or bowel nodule, and low complexity were those where there were no other nodules that has been defined intraoperatively. When we look into the analysis that we have done, overall risk of perioperative complication was more in the group that has received preoperative GnRH. Similar, and in the perioperative complication, the other risk that we most commonly explain to the patient, including the organ injury, hemorrhage, and conversion to laparotomy, were not statistically significantly increased. However, there was statistically significant increased risk of colostomy and ileostomy. And when we looked into the late complication, here I want to tell that the perioperative complication, we include all the patients that develop any complication within 48 hours, and late complications are those complications that are between 6 to 12 weeks after the primary operation. So these late complications were also statistically significant in the patients who received preoperative GnRH, and among them, hematoma was most common complication that has developed. However, the bowel leak, fistula formation, sphere abscess, and embolization, pulmonary embolism was not common. But we know that we have a diverse group of patients, and we need to do the multivariable logistic regression, which we did by controlling confounders, which include multiple confounders in this study. So when we did that, we find that in the perioperative complication, the colostomy was significantly increased in those patients who received preoperative GnRH, and late complications were there, including hematoma formation in this group. This is the data that was after controlling all the confounders. Quality of life for all the patients started from a same base point. However, there was significant improvement in the quality of life in the patients who received GnRH. So this is how the things are. The pelvic pain was improved up to 6 months. However, menstrual pain was improved up to 1 year in the patients receiving preoperative GnRH. When we looked at what we found, our main findings were the risk of colostomy, hematoma, and late complication. We find that preoperative GnRH do improve pain and improve the quality of life postoperatively. However, we find these results. There was no previous study with which we can compare in terms of the complication rate with the preoperative GnRH use. However, we find that the ASHRI guideline do suggest insufficient evidence about the complication risk or preoperative use of GnRH. We have 2 Cochrane reviews that were done about the use of preoperative GnRH in severe endometriosis. However, they have not evaluated the complication risk. There is very limited evidence or a few case series that have shown the evidence in terms of abscess formation with the extensive ureterolysis or electrocoagulation, and a weak evidence about vaginal atrophy and dehiscence, but there were very, very few studies. We find some studies that do suggest that the preoperative GnRH use can reduce inflammation, vascularity, and adhesion formation. What are the strengths of our study? It is the largest prospective database that has been used. It is comprehensive information on all the demographics, surgical technique, perioperative and postoperative complication. We have a comparable data from multiple centers, not only from UK, from worldwide, including USA, Iran, Sri Lanka, and total 6 countries and 101 endometriosis centers. That's why it ensures the validity and generalizability of the study result. And in terms of the statistical analysis, we did multivariate analysis, controlling a lot of confounding factor to see that whether it is really the true effect or not. Limitation is that we had no randomization. There might be some group differences because there was no data that has been collected either on the surgical comorbidities. Moreover, we find that the surgical complexity is the greatest predictor of major intraoperative complications as compared to disease severity. Some of the confounders we can't control were the severity of adhesion, size of bowel nervule, distance from the anal verge. There might be some clinical variation because most complex cases do have been offered by GNRH preoperatively. And there is limitation in terms of the missing data that can contribute to some of the factors in terms of the results. The conclusion, we do suggest that we need to have a careful patient selection and counseling as well. We can counsel that there is no difference in terms of the very common risk that we explain, like hemorrhage, organ injury, fistula formation, leak, death, or sepsis. However, these are some of the perioperative and late complications that are increased. We do know that it is surgery that is done to improve the quality of life. Therefore, we need to inform that there is significant improvement in terms of the quality of life and the pain. And it comes again to a shared decision making when we are talking about the result of this paper. What implication we can have from this cautious use of GNRH, adequate counseling of the patients, telling them about the increased risk, counseling that it may improve the quality of life and the symptom control. What we suggest that keeping in the limitation that we have in terms of producing the results, we do suggest RCT, especially on the NCN classification, so that we have a more valid characteristics of that, how complex the patients were from the very start of the study, and to control that confounding factor. And we hope that by doing further research work, we can help in developing more changes in the future NICE and ASHRI guidelines. And these are, okay, thank you.
Well, thank you very much, Munazza, and thank you for keeping to time. So first of all, as today is a sort of less cramped day in terms of papers and presentations, I think we can invite the audience, if they have any comments or questions, to raise hands, and perhaps, I don't know who's the boss in terms of the Zoom, and we can turn your camera and speaker, the microphone on. So Munazza, first of all, my first question is, did you include patients who didn't have endometriomas in the analysis?
The inclusion, it is not specifically mentioned that whether they have endometrioma or not, but all of these patients do have pararectal dissection.
No, I know. I'm familiar with the BSG database. The reason I'm asking this is almost exclusively the GNRH, not exclusively, maybe I'm wrong in saying that, but normally GNRH analog is applied for patients who have endometriomas. Okay, so if somebody has no endometrioma, sometimes people do, but that's not a very common practice. The practice of putting people on GNRH analogs is usually applicable to patients who have endometriomas. So by comparing the two groups of GNRH or non-GNRH, you may be by extension comparing patients who had endometriomas with patients who didn't have endometriomas. Does that make sense? So I'm making two assumptions here, and I'm aware that these are very approximate assumptions, but let's just explain the assumptions. One is the assumption that everybody with an endometrioma would be put on GNRH analogs. I know that's not the case, but in the BSG world, a lot of people do that. And assumption number two is if they didn't have endometriomas, it's likely that they weren't put on GNRH analogs. If these two assumptions are even remotely correct, then your study in a way is comparing patients with endometrioma and patients without endometrioma. So I would expect patients with endometriomas to have more complications because they usually have more severe disease. Okay. So it would be interesting to see whether if you take that into account and say, okay, I want to see in patients with endometriomas, can I compare these two? And that would be an interesting finding because currently, the way I'm seeing this study, I can explain the higher complication by the fact that they likely had more severe disease because they had endometriomas. The second thing to say is, I think we need to make a distinction between causality with coexistence. Okay, so in the absence of any logical explanation on why GnRH analog can lead to higher complications, because I can't explain it. I don't know. I remember I asked this in the BSGE conference when this was being presented, is you know, how can we explain that if you give someone a medication, then during their operation they are more likely to have complications? So what I take home from this article is, first of all, that was an interesting question to ask. And I think it's important that we question common practices that somehow had found their way into the NICE guideline, which is also surprising because NICE guidelines usually have a very high bar for including a recommendation, that unless there's been an RCT or a very a high level evidence, we don't make recommendations. But one way or another, this did get into NICE guidelines. So I'm in support of doing this study to find out whether it actually does add anything to the mix. And my feeling has always been that it probably doesn't. But the panel, maybe I'll just put you guys on the spot. Can you think of a reason that you present to me in response to my argument of, no, there's no point in putting people on GnRH analogs when they have endometriomas? Can you say something to start with? But Mr. Kazali, have you thought that by giving them GnRH analogs, what can you say to me?
It reduced the vascularity and reduce the
That's
adherence.
one that, yeah, that's the most common explanation that people give. And I think there are two aspects to that, because by reducing vascularity and making the tissue more fibrotic, you can also make the planes stiffer and more difficult to work with. And also, there's also always an anxiety, maybe not a well-founded anxiety, that you may then miss some lesions that you will otherwise see and remove. But there is another reason that I do buy. I think that, okay, there is a point in giving people GnRH analogs sometimes. Can anybody think of it?
Whilst waiting for surgery to help manage their
Yeah,
pain,
that's okay. I hadn't thought of
waiting list.
that. Yeah, that wasn't what I had in mind, but that's a very
Yeah.
relevant point. And Avril.
What?
The other very important factor is the size of the endometrioma. Okay, so you can argue that if you have a smaller endometrioma, maybe you will have a lesser detrimental effect on your ovarian reserve when you do the excision. And I think that has some logic behind it. So I can buy that, that maybe if you need to excise a 3 centimeter endometrioma, you will cause less damage than a 10 centimeter endometrioma.
Yeah.
Could you buy the logic with GnRH analogues reducing vascularity, the effect on the tissue, that contributing to the increase in complication with poor
Oh,
healing?
to the increasing complication. Do you know, maybe. I think it's a long shot. I think, if you can argue it both ways, because somebody may tell you that, no, you're doing a ureterolysis. If you have less vascularity, you have less bleeding, then you use less diathermy and therefore less complications. I get that too. Um, I'm not sure, but I
With
think, as you
the-
said quite rightly, Monazza, the results need to be interpreted with caution. We shouldn't conclude that, okay, GnRH analog leads to higher complications and therefore we shouldn't use it. I still think that it's a tool in our toolbox, and in some patients it's useful. And particularly, as Avril said, if somebody's on the waiting list and GnRH analogs are the only way we can control the pain while they're waiting for their operation, then I think it's a very reasonable thing to do. Is there anything any of the audience want to say? Just raise your hand and we'll bring you in. But in the meantime, I think we should thank Munazza very much for coming on LEJEndo, and I hope that you'll continue coming back, and please let your colleagues know about us.
Thank
Let's carry on with our other articles, which are actually quite interesting as well.
Thank you. I'm going to present on this paper, which was published this month in JMEG by Serraccioli and his colleagues in Italy, looking at the diagnostic accuracy of ultrasonographic features of uterosacral ligaments in endometriosis. So this study focused on improving preoperative diagnoses of the uterosacral ligament endometriosis. It was a multi-center prospective diagnostic study. It included 85 women who then went on and had laparoscopic resection of endometriosis. It was carried out in 2 tertiary centers in Italy, and the objective was to evaluate which ultrasound features best predict USL endometriosis. And as the disease was resected, histology was the reference standard for these cases. So looking at the ultrasound features that they looked at, the most prominent that they referred to in the study is the USL anterior posterior thickness measured in millimeters. So this study was very descriptive on how this was measured. So the transvaginal probe was put into the anterior fornix, transverse plane, and then taken to laterally to then measure the uterosacrals on both sides at the level of the cervical canal. You can see this here in this ultrasound image. So looking at the left uterosacral ligament, you can see this hypoechogenic region here, and you can see the ultrasound calipers on there measuring the anterior posterior diameter. The sonographers also commented on the echogenicity and on any irregularity of the peritoneum, tenderness on probe pressure, and also presence of contiguous endometriotic lesions. And they define this as lesions on the ipsilateral ovary, the parametrium, and also the nearby rectum. And then you can see the intraoperative image corresponding to the same patient there with the left uterosacral disease. And as I've mentioned, the reference standard was histological confirmation of USL disease. So looking at the results, they were able to show that there was a statistically significant difference in USL thickness in those with endometriosis measuring 5 millimeters compared to those without USL disease with measuring 3.3 millimeters with a p-value of 0.01. They then used an ROC curve to find the optimal cutoff for diagnosing USL endometriosis, and they calculated that depth to be 4.2 millimeters. And that depth gave a sensitivity of 57, specificity of 86%, and an area under the curve of 0.72. As far as sort of diagnostic tools and taking statistics into account, an area under the curve of less than 0.75 was deemed to be a low accuracy for a diagnostic tool, whereas greater than 0.75, it was deemed to be moderate accuracy for diagnoses. They also noted that patients with USL endometriosis, it was strongly associated with echoic lesions and also irregularity in the peritoneum, as well as tenderness with the probe and contiguous rectal lesions. So as I showed, with just the thickness of the USL being measured at 4.2 millimeters or greater, the area under the curve was just 0.72. So then what the authors then did was look to see whether if you combined different other ultrasonographic features, whether that could improve the accuracy of the diagnosis. And actually, if you did combine an increased thickness of the USL together with any of those four shown here, actually it does cross over into a moderately accurate diagnostic tool for diagnosing USL disease. So the area under the curve reaches that 0.75, which is deemed moderate accuracy. So in conclusion, they conclude that USL thickness above 4.2 does indicate endometriosis, but it's not sufficient enough to diagnose it alone. But actually, when you combine it with other features, it can improve the diagnosis. And actually, this is there aren't many papers that look at specifically at uterosacral ligament features and in particular the depth of that. So this was one of the first papers that did look at there being such like a threshold. The paper does support targeted surgical planning and patient counselling. So if you're able to combine these ultrasound features suggesting USL disease, you may be counselling the patient or may be more inclined to counsel the patient about possible hypogastric nerve involvement, speak to them about potential voiding dysfunction, need for intermittent south catheterization if they are going for surgical resection. But as always, further validation in larger non-surgical populations is needed. So this was one of the limitations that the authors spoke about. All of the 85 patients included in this study then went on to have surgery. So there certainly is a selection bias in that. They also mentioned with regards to diagnosing it preoperatively, very significantly, they've missed out clinical examination, which certainly does contribute, it plays a huge factor in diagnosing uterosacral disease. But also, interestingly, they didn't note what point in the cycle the patient was with the ultrasound. And I didn't think that would have a significant impact. But actually, when you're talking about millimeters of the uterosacral ligament, whether increased inflammation or vascularity can actually make a difference, and whether that would skew their results, I'm not sure, but it's something that they did mention in their discussion, which I thought was interesting.
What do you think, Flo, about targeted surgical planning and counseling? And how far do you think we should take it? And when does it stop being productive and maybe start being unproductive? Am I making sense? So, for example, go on.
I think it plays a very significant role in the cases of joint cases and being prepared to see if there is bowel involvement and making sure that the right team is involved, etc. When it comes down to the exact, involvement of the left uterosacral ligament, actually, even with the powers of a very good ultrasound or MRI, you never know exactly what you're going to get.
Yeah, I agree. I think, I've known about how the team in Bologna practice, which is very impressive, that they are so good, and all of them, all the team, Nadine came from that, Mohammed came from that, and Renato Serracchioli is amazing, and all the authors in that are great surgeons, and they do a really good job there. But and you know, I know that I think it was Marco that messaged us from Avellino. I know that in Avellino, Zakaria actually, yeah, Marco. Um, they have an amazing person who does the ultrasound and can tell them exactly what the disease is. I agree with you, Flo, that you know when it comes to counseling, if I say to the patient in the consent form that excision of left uterosacral ligament, what am I going to do when I go in and see that there is also right uterosacral ligament involvement, which is, according to the same study, in the best hands, you can miss in a significant number of patients. So I still think we will have to counsel the patients for all of those risks, including, you know, bladder dysfunction and all the rest of it. And maybe we should still, as we do always, counsel them for, we will excise endometriosis wherever we find it. And I think you're right in saying that the importance of the targeted surgery and surgical planning, it really matters a lot more when we're dealing with, has it gone into the bladder? Has it gone into the bowel? How deep? How big? Do I need to do a segmental a disc, you know, ureteric reimplantation, etc.? When it comes to less severe disease that for the rest of the pelvis, I'm not certain if the value is the same. But I don't know what you guys think.
So what do you think about the role of intraoperative scanning?
I think the main advantage of doing that is training, you know, so that when you then scan someone in clinic, you have you know learned you've seen it exactly there and then you can see if you've been correct or not. I think that's the main role. But equally, as you know, Flo, we recently had a patient where Davor Jurkovic had scanned and told us that there is a uterosacral ligament nodule. We went in and it looked absolutely normal. You know, we could not see any endometriosis. This patient was very symptomatic. In the end, after a lot of back and forth, and I even remember de-scrubbing to think about this and look at the ultrasound images, because Davor, as you probably know, is excellent. You know, if he reports something, it almost certainly is there. So in the end, we decided to excise that uterosacral ligament, even though it looked completely normal. And Flo, you can tell the audience what we found. Do you
Well,
remember?
histology came back.
Yeah,
He responded saying that she felt
yeah.
measurably
Histology,
better.
but yeah,
Pain
exactly.
had gone, and now she's pregnant.
Yes. So go figure. So that's
Was the histology positive for endo?
Yeah.
positive for endo, and
Oh,
her pain went away, and she got pregnant. Now, this was a normal looking uterosacral ligament. Okay. Now, when you think you've seen it
interesting.
all, yeah, when you think
That's
you've
very
seen it all,
interesting.
then you see something like this coming along. Again, I'm not suggesting that we need to now go and remove normal
Normal
looking
looking.
uterosacral ligaments and pelvic sidewalls. But when you have someone like Davor telling you that there is a nodule here, I can see it, and the patient has symptoms, then maybe there's an argument.
When you looked at the ultrasound images, did it look convincing? Like what Flo
Sort
has
of, but again, to
reported?
my eyes, you know, I can see the picture that is marked. Okay, this is a
Mm.
uterosacral ligament nodule. Okay, we have only 5 minutes. Let's
Oh,
go
yeah.
to the last one, which is also an interesting.
Yep. So, my paper is a study done by a team from Hungary and published in Pain Medicine last month. And this was a systematic review used to evaluate the efficacy of various physical therapies in alleviating endometriosis-related pain. Next slide. So, the team used the PICO strategy. So, population, women with endometriosis-associated pain, intervention, physiotherapy techniques, comparison, non-physio techniques, outcome pelvic pain changes. So inclusion criteria, application of various physio techniques, being a female diagnosed with endometriosis and experiencing pain, and the use of a 0 to 10 point pain measurement scale or something equivalent to that. In terms of exclusion, they excluded non-conventional physical therapies like acupuncture, yoga, Pilates, population with disease other than endo, those with endo and not having pain, studies involving animal or in vitro studies, studies not reporting pain as an outcome. Okay, next slide, please. So they used PubMed, Embase, and Cochrane database. There were 2 independent reviewers, and in the end, 8 papers were eligible for the study. 7 were RCTs, 1 were retrospective, and the total sample size was 433 patients, ranging from 30 to 154 participants. What they did as well is they divided the studies into 3 different categories based on the way they delivered physiotherapy. So the first group is what they call physiotherapy modalities. That means they use energy to deliver treatment, such as electrotherapy, TENS, neuromuscular electrical stimulation, laser therapy. And there were 4 studies that discussed this. The second group that they used was exercises that was the group that used exercises that include various movements. 2 studies delivered this. So one was using exercise groups, and another study was using a telehealth delivered exercise and VR delivered exercise. And then the last group was 2 papers which use manual therapy. That means they use methods that use their hands, like massaging. One of the papers, the third paper down, Gomez et al., had a protocol of a combination of soft tissue and articulatory techniques. Okay, comparison groups were no treatment, placebo, or any other non-physiotherapeutic techniques. So if we go to the next slide, this meta-analysis showed that regardless of any specific method, physiotherapy in general were more effective in reducing pain than non-physiotherapy techniques, resulting in an approximately of 2 points on the pain scale. Next slide. So out of the 3 different categories which I mentioned just now, it showed that physiotherapy modularities, that means the group that use TENS, laser therapy, etc., were the most effective techniques in reducing pain. Although found effective to be reducing pain, they were the only method that mentioned the availability of side effects. This ranges from headaches to muscle spasms, occurring during electrotherapy intervention, and none were reported in those undergoing laser therapy. In terms of the 2 studies that looked at manual therapy, they were successful in reducing pain, but did not yield a statistically significant difference. And the exercise group also similar, but not effective as the manual therapy or the physical modalities. Next slide, please. They also did a meta-analysis looking at application application site of the pelvic pain on pain change. And out of the 7 studies, 5 used locally applied intervention, 2 used generally applied interventions to relieve pain. And the study has shown that the locally applied intervention is more effective. So the conclusion of the study is physical therapy is superior to the comparison groups in relieving endometriosis-associated pelvic pain. I really like their recommendation. So first one is physical therapy should be recommended by clinicians in their therapeutic option. More specifically, it should be easy for women to access this treatment, such as physiotherapy modalities should be made available in endometriosis and pelvic therapy clinics. To help women with endometriosis manage their pain independently and increase their autonomy, classical massage techniques, pelvic floor exercises, and exercise that can be performed at home should be prescribed by doctors and physiotherapists in addition to medication. And the third recommendation they had was to reduce the possibility of dependence on painkillers and its side effects. Consumption of painkillers should be restricted if physiotherapy techniques are found to relieve pain. And that's all from me, actually.
Thank you very much. I think more and more we are integrating physio in our work, and I'm seeing a lot of good results from it. I just wished I understood it a bit more, and maybe I should go and sit in one of the physio clinics where Alicia is doing that. Have you guys seen women's health physio in action when they do interventions?
No, I haven't actually. Just
I've seen ours actually, ours Avril for St. Peter's. I've
Tell us.
been to one, and she's very, very good. My comments, I'm not a physiotherapist. My comments would be, I think it's a lot to do with the setting as well, and there's a lot of, it's done in a leisure centre. There's a lot of general health promotion, exercise, swimming, yoga. A lot of her appointment was more about promoting other aspects of physiotherapy and general physical therapy rather than actually performing exercises. But yeah, I think
Did she do any manual examinations, any trigger point thing? And
yes,
okay.
she does that when we as clinicians specifically comment on the need for pelvic floor muscle relaxation, if there's dyspareunia, if we've noticed thickened uterosacral ligaments at examination. Yeah, but I think they make their own judgment call as well as to when it's needed. Yeah.
Yeah, I'm seeing more and more positive effects from it. Okay, guys, we're out of time. I'm very grateful to the team for presenting, and Flo especially for putting it all together, and Munazza for being our featured presenter. Sarah and Avril, your papers were great. Thank you very much. And the next one is the 6th of September. Flo, do we know who's presenting?
Yes, oh, can you see it now? Nash Marag
Yeah.
doing
Okay, yes, Nash from from Florida, US, is going to present this to us. It's going to be a very interesting article again on AI, and maybe our paper will be ready by the end of the year. Maybe we can present ours at some point. Okay, wonderful.
All right. Thanks, everyone.